Years of damage leave a pancreas that can no longer feed the body. Greasy, floating stools, and a rising blood sugar completely tell the story. All right, let's jump right into this explainer and master the exact details of chronic pancreatitis that you absolutely need to know for the NCLEX.
I want you to picture a ruined, calcified factory that can't produce its essential goods anymore. Honestly, that is the exact core visual you need to anchor in your mind for this disease. Whenever you hear the words chronic pancreatitis, immediately see this burned-out factory, just quietly failing.
Section 1. The burned-out pancreas and its pathophysiology. Let's walk through exactly how this factory burns to the ground. So it all starts with repeated injury. Recurrent inflammatory attacks, which are overwhelmingly driven by chronic alcohol use and, severely accelerated by smoking, just chronically inflame the gland. Over time, that healthy functional tissue is permanently replaced by fibrosis and calcification. The ducts narrow. The scar tissue literally chokes out the acinar cells, which leads to exocrine failure. So we lose our digestive enzymes. And it also chokes out the islet cells, causing endocrine failure. So we lose our insulin. The gland just completely shuts down.
Moving on to Section 2, assessing signs and symptoms. Let's talk about what the nurse actually sees at the bedside.
These are your absolute hallmarks. First up, steatorrhea. Those fatty, really foul floating stools are basically pouring out of the patient because the lost digestive enzymes mean dietary fat is entirely unabsorbed. You'll also see profound weight loss and malnutrition because of this malabsorption. Plus, new-onset diabetes with high blood sugar because those insulin-producing islets are just completely dead. And of course, there's chronic epigastric pain that might radiate to the back, though interestingly, this pain can actually lessen as the gland completely burns out.
Now, the crucial point here, and I'm telling you this is a massive NCLEX trap, is that unlike acute attacks, amylase and lipase are often perfectly normal or maybe just mildly elevated here. Why? Because the gland is literally too dead to secrete anything. Instead, what we look for is a low fecal elastase, which confirms that exocrine insufficiency, and high glucose, signaling endocrine failure.
This comparison brilliantly illustrates why you absolutely cannot mix these two up on exam day. Acute pancreatitis, that's a sudden crisis with sky-high enzymes, severe pain, and a real risk of shock. But chronic is a totally different beast. It's progressive, irreversible scarring with completely normal enzymes, presenting mostly with steatorrhea and diabetes.
Section 3. Priority nursing interventions. So how do we rescue the patient and treat a factory that just doesn't work?
Well, we basically have to do its job for it. Here's your priority sequence. Number 1, we absolutely must artificially replace the factory's lost goods. We do this by giving pancreatic enzymes directly with every single meal and snack. Number 2, aggressively manage their new diabetic state with glucose monitoring and insulin. 3, support their nutrition. We're talking a low-fat diet, frequent meals, and fat-soluble ADEK vitamin supplements since they can't absorb fat on their own. 4, manage that chronic pain. And 5, strict alcohol and smoking cessation to stop any further destruction and lower their extremely high risk for pancreatic cancer.
Section 4, patient teaching and management. Keeping them safe at home requires some razor-sharp education.
This is especially true regarding those replacement enzymes. You have to drill this into your patients. Taking pancreatic enzymes on an empty stomach does absolutely nothing. Think about it. The enzymes are there to digest the food. If there's no food, there is literally no need for them. They must take them right with their meals to actually activate that digestion process.
Section 5. NCLEX Test Yourself Quizzes. Let's put this explainer to the test with some active recall. Drop your answers in the comments as the timer counts down.
Here's question 1. A client with chronic pancreatitis is prescribed pancreatic enzyme replacement. The nurse teaches the client to take the enzymes A at bedtime only, B with each meal and snack, C on an empty stomach, or D only when pain occurs. Lock your answer in 3, 2, 1.
Excellent. The correct answer is B. Pancreatic enzymes have got to be taken with food to actually aid the digestion and absorption of nutrients. Taking them apart from meals is completely ineffective because remember, if you don't take the enzymes with the food, the fat simply won't digest.
All right, let's try one more to really cement those clinical signs. Question 2. Which finding indicates malabsorption in a client with chronic pancreatitis? A. Dark, concentrated urine. B. Constipation with hard stools. C. Foul-smelling, greasy, floating stools. Or D. Bright red rectal bleeding. You've got 3 seconds on the clock. 3, 2, 1.
Spot on, it is C. Steatorrhea is the absolute hallmark sign that dietary fat is pouring out completely undigested, and it's all due to the loss of pancreatic lipase.
Always remember, your ultimate anchor for this disease, a burned-out pancreas equals lost enzymes and lost insulin. But really ask yourself, if the pancreas completely stops producing insulin, how does this permanently alter the patient's entire lifestyle moving forward? If this explainer made it click, subscribe. One killer MedSurge topic every day until you pass the NCLEX.